Welcome to this clinical training module on postpartum hemorrhage or PPH. As a leading cause of maternal morbidity and mortality worldwide, PPH is a critical obstetric emergency that requires a standardized, rapid response. This protocol is designed to equip clinical staff with the essential skills to identify, assess, and manage PPH effectively to ensure patient safety. Postpartum hemorrhage is clinically defined by the volume of cumulative blood loss following delivery. For a vaginal birth, PPH is identified when blood loss reaches 500 milliliters or more. For a cesarean section, the threshold is 1,000 milliliters or more. Immediate recognition of these specific volumes is the first step in activating the emergency management protocol. To ensure accuracy, blood loss must be quantified rather than estimated. This is achieved by weighing all saturated materials, including pads, drapes, and sponges. The clinical standard follows a simple conversion where 1 gram of weight equals 1 milliliter of blood. This objective measurement provides a clear trigger for intervention and helps the medical team track the severity of the hemorrhage. While quantifying blood loss, clinicians must simultaneously assess the patient's vital signs to determine hemodynamic stability. Close attention should be paid to blood pressure, heart rate, and respiratory rate. These physiological indicators help the team understand how the patient is compensating for blood loss and guide the urgency of fluid resuscitation and other life-saving medical interventions. The 4 teraseconds framework helps identify the underlying cause of PPH, starting with tone. Uterine atony, or the failure of the uterine muscle to contract after delivery, is the most common cause, accounting for 80% of cases. Risk factors include prolonged labor, uterine overdistension from multiple gestations, or a large fetus, all of which prevent effective uterine contraction.
The next 2 causes are trauma and tissue. Trauma involves lacerations to the cervix, vagina, or perineum that occur during delivery and require surgical repair. Tissue refers to retained placental fragments or membranes left inside the uterus. These fragments physically prevent the uterus from contracting fully, leading to persistent bleeding that will not stop until the remaining tissue is removed.
The final T stands for thrombin, which refers to pre-existing or acquired coagulopathies. These conditions impair the blood's ability to clot, significantly exacerbating any bleeding. Identifying clotting disorders is essential, as standard mechanical or pharmacological treatments for atony may not be sufficient if the patient's underlying coagulation system is failing during the obstetric emergency. Once PPH is identified, the primary nurse must remain at the bedside to initiate care, while a second team member activates the obstetric emergency response team or contacts the physician. The first-line mechanical intervention for suspected uterine atony is vigorous fundal massage. This physical stimulation encourages the uterine muscles to contract and is a vital immediate step in controlling blood loss. Continuous monitoring is mandatory throughout the management process. Vital signs and the state of the uterine fundus, including its firmness and location, must be assessed and documented every 5 to 15 minutes. This high-frequency tracking allows the clinical team to evaluate the patient's response to treatment and decide if further escalation or different pharmacological agents are required. Establishing large-bore intravenous access is a priority for fluid resuscitation. Clinicians should begin an infusion of isotonic crystalloids, such as normal saline or Ringer's lactate. An initial bolus is typically administered, followed by a maintenance infusion that often includes a uterotonic agent like Oxytocin. A common mixture is 20 units of Oxytocin in 1 liter of fluid at 60 drops per minute. Pharmacological intervention is used to promote sustained uterine contraction. Standard protocols include administering 10 units of Oxytocin intramuscularly or 0.2 milligrams of Methergine intravenously. However, clinicians must be vigilant regarding contraindications. For instance, Methergine should never be administered to patients with hypertension, as it can cause dangerous spikes in blood pressure. As the team manages the immediate bleeding, they must also prepare for potential blood transfusions. This involves arranging for immediate blood typing and cross-matching at the lab. Depending on the volume of blood loss and the patient's hemodynamic status, the team must be ready to administer packed red blood cells and other necessary blood components to maintain oxygen delivery. If bleeding persists despite mechanical and pharmacological efforts, the care must be escalated. This may involve preparing the patient for a dilatation and curettage procedure to remove suspected retained tissue. During this phase, prophylactic antibiotics like ampicillin and metronidazole are administered to prevent secondary infections, ensuring a comprehensive approach to the patient's recovery and long-term health. In conclusion, the effective management of postpartum hemorrhage relies on a systematic, rapid response centered on the 4 teraseconds framework. By combining accurate blood loss quantification, vigorous fundal massage, targeted pharmacological agents, and fluid resuscitation, clinical teams can stabilize the patient. A coordinated, multidisciplinary approach is the fundamental key to controlling hemorrhage and ensuring positive maternal outcomes.